Glad to have everyone with us. Pericardial disease is one of those topics that pops up everywhere, from wards to boards. But before we get into the weeds, let's make sure we're all picturing the right thing. Picture a thin, double-layered sac cradling your heart. That's the pericardium.
I can totally visualize it now, almost like a Ziploc bag keeping the heart safe. But it comes with its own set of problems, right? You mentioned there are 3 big ones we need to nail down.
Absolutely think of them as the big 3. Pericarditis, pericardial effusion, which can turn into tamponade, and constrictive pericarditis. Each has its own vibe, but they all revolve around how that sac interacts with the heart.
That actually makes it easier to sort things in my mind. Could we kick off with acute pericarditis? That's the one people see most, right?
Definitely. Acute pericarditis is basically inflammation of the pericardium. Most patients show up complaining of chest pain, but it's got some dead giveaways, like being sharp, worse when they breathe in, or when lying flat. Sitting up or leaning forward, that's usually their sweet spot for relief.
Wild how those position changes are so classic. But does that pain always mean a quick recovery? Or do some folks get stuck with it coming back again and again?
Some patients do get lucky and recover fully, but here's the catch. Recurrence is actually a common issue. So chronic therapy becomes necessary for people who have repeat episodes.
I had no idea. So, besides pain, what other clues tip us off that this is inflammation and not something else?
Good question. Since pericarditis is all about inflammation, patients may run a fever, have leukocytosis, or show elevated ESR. Those labs scream inflammation. But here's the twist. They don't make the diagnosis by themselves.
That makes sense. You want clues, not a slam dunk. Oh, and the friction rub, that scratchy sandpaper sound, how reliable is that for diagnosis?
It's pretty iconic if you catch it scratching in both systole and diastole. But not every patient has it, so it's more like a cherry on top rather than the whole sundae.
So, to actually diagnose pericarditis, you're relying on a combo, right? What's the checklist you go through?
Exactly. It's a clinical diagnosis, no magic blood test. You need 2 out of 4. Classic chest pain, friction rub, ECG changes like diffuse ST elevation or PR depression, and pericardial effusion. Miss any of those, and you need to keep looking.
It's almost like building a case for pericarditis. And echo is non-negotiable, right? Because half of patients develop an effusion, and you don't want to miss a looming tamponade.
Absolutely. An echo lets you spot that black space around the heart or even catch early signs of tamponade. Plus, it's quick and non-invasive. Speaking of causes, do you know what the usual story is behind pericarditis? Most cases are idiopathic, but right behind that, viruses, especially Coxsackie, are the big culprits. There's often a recent upper respiratory infection, then a few days or weeks later, boom, chest pain and inflammation.
I remember reading about other causes. 2 bacteria, if someone has pneumonia or surgery, even uremia in kidney failure. And then there's the autoimmune angle, like lupus or rheumatoid arthritis. Kind of a rogues gallery.
Absolutely. And for boards, a classic trick question. If it's uremic pericarditis, the answer is hemodialysis, not anti-inflammatory drugs. The post-MI syndromes are also fair game. Early fibrinous pericarditis, and Dressler's weeks later due to an autoimmune reaction.
That's a lot of memorizing, but those patterns really help. Now that we've got causes and diagnosis, what's the typical game plan for treatment?
Management usually starts with NSAIDs, naproxen, or ibuprofen. If that's not enough, glucocorticoids come in as a second line. But here's an important twist. Colchicine is added to reduce the risk of recurrence. It's not just for gout anymore.
Funny, you mentioned colchicine. I used to only associate it with gout flares. So most patients end up on NSAIDs and colchicine for a couple of months, and that's usually enough to get them over the hump?
Exactly. Most go into remission with that combo. But let's pivot to what happens when fluid builds up in the pericardial space, pericardial effusion and the dreaded tamponade. So pericardial effusion is just that fluid in the sac. Most folks won't feel a thing unless the pressure cranks up and triggers tamponade, which can get life-threatening fast.
It's wild that the amount of fluid isn't the only issue, it's how fast it accumulates. Trauma or bleeding fills the sac suddenly, and even a little can be disastrous. Meanwhile, chronic cases like cancer inch along for a while before causing trouble.
Exactly. And on chest x-ray, A big effusion makes the so-called water bottle silhouette, but that doesn't mean tamponade is happening. For that, we look for classic features: distant heart sounds, elevated jugular vein pressure, and dyspnea, especially without pulmonary edema.
That brings up Beck's triad, right? Distant sounds, high JVP, hypotension. And for exams, everyone loves asking about pulsus paradoxus, a drop in systolic BP when the patient inhales. But it can show up in asthma and COPD too.
You're totally right. Diagnosis hinges on both clinical and echo evidence. Look for pulsus paradoxus. See the effusion on echo. If tamponade's there, first move is IV fluids to boost preload. Never ever give diuretics, or you risk cardiac arrest.
That's always a gotcha on exams. IV fluids first, then get that fluid out either by pericardiocentesis or surgically with a pericardial window. And right heart cath shows equalization of pressures, right?
Exactly. And as for causes, tamponade usually follows pericarditis, trauma, or cancer metastasis. But when it comes to chronic pressure, that's when constrictive pericarditis enters the picture.
So constrictive pericarditis is rare but legendary for test questions. It's like the sac turns to cement, calcified, fibrotic, and squeezes the heart, right?
Exactly, imagine the heart trying to beat inside a suit of armor. Most patients get symptoms of right heart failure: dyspnea, raised JVP, leg swelling, even nutmeg liver from congested blood flow.
There are some wild exam findings too, like the pericardial knock and Kussmaul sign, where JVP rises on inspiration. And here's a mnemonic pulsus paradoxus for tamponade, K for Kussmaul in constrictive and restrictive disease.
Love that trick. For diagnosis, a chest x-ray is your best first step. It may show calcifications. Echo isn't super helpful, but right heart cath again shows equalized pressures. The only cure is surgical. Crack open that pericardium and let the heart breathe.
That's a dramatic fix. Looking at all three diseases together, the patterns really help to lock in what's going on.
Totally agree. If you can remember, pericarditis is inflammation. Effusion and tamponade are pressure problems. And constrictive pericarditis is about the heart being encased in a stiff shell. You'll ace any question that comes your way.
That summary is a game changer. 3 diseases, 3 core problems. Thanks for breaking it all down. It's been nothing but high-yield pearls today.
So now that we've wrapped up pericardial disease, pericarditis, effusion, tamponade, let's zero in on the heart structure, specifically the valves. There's so much exam gold here.
Jumping from the outer layer to the valves feels like a natural step. I mean, these valves really act like the heart's traffic lights, making sure blood flows in the right direction and not causing any chaos.
Exactly. And honestly, if you're prepping for clinical rotations or boards, valvular heart disease is everywhere. Let's break it down so it actually sticks.
Totally agree. It's wild how much rides on those tiny leaflets opening and closing just right. So, what's the simplest way to categorize all the drama they cause?
All valvular heart diseases basically split into 2 big buckets: stenosis, where valves won't open well, and regurgitation, where they won't close tight enough.
Does that mean stenosis is about the valves being stiff and making it hard for blood to go forward? Like a door that's stuck and won't open fully?
That's spot on. The valve leaflets get thick and rigid, so blood flow gets blocked. Patients can get pretty symptomatic with even moderate narrowing.
And regurgitation flips the problem where the valve's more like a door that doesn't shut, letting blood leak backward. Makes sense. I've seen that cause some weird heart sounds during exams.
Let's take regurgitation a bit deeper, because not all leaks are created equal. Acute versus chronic regurgitation comes up constantly on exams.
I always wondered, why is the timing so important? An acute leak seems like it'd be a bigger deal, but what's the real difference clinically?
Great question. When regurgitation hits suddenly, like from an infection or valve rupture, the heart just can't adapt. Patients can crash with low blood pressure or even shock.
But if it's chronic, the heart slowly stretches to accommodate the extra blood over months or years. So they wind up with heart failure symptoms instead of a sudden crisis. That actually clears up a lot.
Whenever you're thinking about a valve issue, there's one test that's basically a reflex: the echocardiogram. Specifically, the transthoracic kind.
That makes sense since echo lets you literally see the valves moving, right? Plus, you can spot things like gradients for stenosis or backward flow for regurgitation.
Exactly. Echo is king for both structure and function. And just a heads up, EKGs don't really help with valve disease. They might show chamber enlargement, but not what's actually happening at the valve itself.
I appreciate that reminder. So many people order EKGs out of habit, but it really doesn't get to the root of valve problems. Echo is where it's at.
Switching gears to treatment, here's something everyone should know. We only treat severe valve disease. Most mild to moderate lesions are just watched with regular echoes.
That's usually because fixing the problem means surgery, right? So you don't want to jump in unless it's really needed.
Exactly. And when surgery is needed, you get to choose between bioprosthetic valves made from pig or cow tissue. No lifelong blood thinners required, but they wear out, or mechanical valves, which last longer but require anticoagulation forever.
And there's even balloon valvuloplasty for some cases, like certain types of stenosis. Not every patient has to go straight to the OR.
Funny you mentioned alternatives. Medical therapy is pretty limited here. Only two main situations: managing heart failure symptoms with diuretics, or using vasodilators and regurgitation to help blood flow forward a bit better.
So meds can help with symptoms, but don't really fix the valve itself. I guess that's why surgery is usually the main way out.
Exactly. Now, you'll definitely see questions about why valves get damaged. Rheumatic heart disease and carcinoid tumors are classic high-yield causes.
Rheumatic heart disease especially loves the mitral valve and shows up years after untreated strep infections, usually in areas without widespread antibiotics. Carcinoid, on the other hand, hits the right-sided valves thanks to serotonin. Those clues always pop up on boards.
Now that the big framework's in place, stenosis, regurgitation, diagnosis, treatment, and cause, let's zoom in on individual valve diseases. Aortic stenosis is up next, and it's a favorite for exam writers.
That's the one with the classic symptom triad, isn't it? I always picture the fainting, chest pain, and shortness of breath together.
Exactly. And the murmur is so distinctive. We'll break down all the clues you need to catch it both in real life and on tests.